Thank you, and thank you to the Alliance and all the parents for sort of putting this together and for me to have this opportunity to talk a little bit about I haven't used a PC in a long time. Okay. To talk a little bit about mental health management, specifically, in epilepsy, and that includes the kids who have the PCDH19 deletion, and how can we approach caring for these children and helping their families. So these are my disclosures. It's a health fund, which is an integrated program, and it's a startup. I don't know why I have to put that up as a disclosure because it makes negative money, but it's there. So really, as I've been listening to all the different talks yesterday and today, it's become very clear to me there's a lot of amazing research going on, and hopefully, all of this will lead to sort of what ultimately we all want is a cure. But I'm also very I'm a pragmatist, and I like to think about, well, while you're waiting, while we get there, like, what can we do now? Because it's great, that all this work is going on, but what can we do now? And then when you can't change the diagnosis, when you can't change the symptoms, I tend to think of it, and I think yesterday somebody brought it up, one of the parents, can we then look at quality of life? When we can't change anything else, is there a way to at least work on quality of life and what contributes to sort of having a better quality of life? And some of it might be my bias because I'm a mental health professional, but when I talk to a lot of patients, and I work really my entire career, 7 or 8 years now, has been in working with kids with all kinds of different medical illnesses and overlapping mental health issues. And one theme that comes up again and again is sort of the behavior and the mental health problems are one of the biggest sort of pieces of the puzzle in terms of quality of life impairment. And so I often like to think about, what can we do to address that piece of the puzzle? So I'll talk a little bit about what that piece is, and I won't belabor it because you heard a lot about, already the behavioral health issues and the mental health issues that through the data that was just presented. But I'll briefly go over that, and then really kind of talk a little bit about the background or the theoretical background of then how do you take this and create services and clinical programs, because it's one thing to know somebody has autism, they need ABA, and they need speech therapy and occupational therapy. It's a whole other animal, like what's your insurance? Is your regional center going to accept you? Do you even have child psychiatrists where you live? There are certain states where there's like 1, maybe 2 child psychiatrists for the entire state. So it's really, really difficult. So how do you then think about care models that address some of these real life challenges? And then I'll talk a little bit about the program, and I just sort of put this word together, so I don't know, I've talked about it earlier, but collaborative kind of care collaboration for pediatric epilepsy that I'm trying to see if we can all work together with our neurologists to put a program together. I guess let me talk about this. You heard a little bit already about the mental health issues in PCDH19, some of the intellectual disability, which is pretty common, autism, and I've put their features because, just being a child psychiatrist, I guess I get a little picky about what we call what, and it's really important because, children with intellectual disabilities can have a lot of behaviors that get in the way of them interacting socially, and that can seem very repetitive and very ritualistic, but they're not necessarily the same as having autism. Because the social piece it's not so much social motivation as it is sort of all these other things getting in the way of actually executing on the social motivation. And I think that's really important because the kinds of treatments we would use are slightly different when there is no social motivation versus when there is motivation and you can't really execute on it. And then attention difficulties and anxiety, and I put anxiety there even though you didn't look it up on the data, because from my perspective, a lot of anxiety can look as acting out and can look as sort of uncontrolled ADHD-like behavior when it really is driven by underlying anxiety. And it's hard to know unless you do sort of more thorough evaluations. And sort of going back to so when I started thinking about mental health issues in this population with the deletion, I sort of wanted to zoom out. I'm really kind of a big picture person. So I wanted to zoom out and look at how does this compare to what we know about epilepsy in general. And if you look at the rates of psychiatric disorders in epilepsy across the board, 30% of the kids have some psychiatric diagnosis. And this is really sort of a conservative estimate, and usually applies to kids who have more sort of easily managed, simple, or kind of lower end of the spectrum of epilepsy disorders. If you look at the numbers for more complex or difficult to treat epilepsy syndromes, they're more in the 50 to 60% range, which sort of fits with the data that you heard about earlier, which is a lot more frequent than the general population. And it depends on the kind of epilepsy, the medications that you're taking, because a lot of medications that are used for epilepsy cause mental health or at least behavioral problems. And then when I say family variables, it's really looking at, is there family history, is there genetic sort of reasons for there to be mental health issues that might be independent of the epilepsy or not. And we also see higher rates of mood and anxiety disorders. And this is where I feel like often when I talk about this, parents are either surprised or feel like, why are there such high rates? And again, the way I look at it, I think when we decided that we were going to split up certain parts of the brain into neurology and psychiatry, we forgot to tell our brain. And so it sort of shows up, in the same manifestations because it's the same organ at the end of the day. So that's just sort of, kind of all the, and like I said, I don't want to go into too much detail about the different diagnoses because you already heard about it. But so if we know that there are high rates of diagnoses of mental health issues in these kids, why don't we just sort of say, okay, let's refer them to mental health and sort of that'll take care of it? Why does care as usual not work? And a lot of it is because a lot of kids, and this is not specific to epilepsy, this is sort of across the board mental health issues. Most kids with mental health issues don't get treatment. And there are, I think, multiple reasons that drive this. A lot of it is access to care because it's hard to find a mental health care provider. A lot of it is, if you can sort of find a mental health provider, kind of really the social burden and the stigma and insurance, and then sometimes just the practical aspect of getting to the appointment, all of those things contribute to that. And even when people do receive care, there's usually sort of 3 visits. That is the average number of visits that people who go to mental health care have, which is not enough. We can't, I wish we were able to really cure and fix mental health problems in 3 visits. That would be fabulous. But we're just not there yet. And then, often when we are starting to embed services in primary care to say, all right, at least we'll find patients with mental health issues in their primary care settings. The problem is that often patients who have mental health problems don't even show up as often to their primary care provider's office. And a lot of this data is especially true in children with autism because it's a whole ordeal to just take a patient to a primary care doctor's office. And then take them there when there are hopefully no other kids running around and screaming and all of that. So it's really, care as usual does not work. So what do we do with that? All the insurance issues or the access issues and cares. And our hope is that integrating care can really shift some of this and start putting the services where the patients are. And there's a lot of literature, and this is sort of the wave now as we are moving into this era. And this is, again, me sort of thinking from a systems perspective. How do we put into place effective systems of care? Integrated care is becoming the new thing as we move into accountable care organizations. Because we're starting to look at how can we improve outcomes for patients, and if you don't address mental health issues, outcomes are going to not look good. And there's lots of data to support across medical illnesses. If you don't address mental health, the outcomes from medical illnesses are not great. So there are lots of different models. I really just put it out there to show that it's a mess of like, we can do this and we can do that and we can do that. And, maybe we need to put somebody who can help you make a call to your psychiatrist and call your neurologist, or, we can kind of put them in the same building and hopefully they'll talk to each other. So there are lots of different ideas, that are put out there in terms of how to actually integrate care. But the way I like to think about it is really when you think about integrating care, who are you integrating, what are you integrating, and where are you integrating it? And so, if you look at just coordinating care or getting better coordination, you can have patient navigators and more effective screening. And so where does the screening happen? Usually in the sort of primary care health home. Where are the navigators? So who is the navigator is the answer, and sort of what is the coordination is being integrated. And then if you look at co-location, this is where I talked about putting them in the same building. And really the ideal is looking at really high-level system integration. And this really is, I know we have colleagues from Illinois and Australia, and this is really sort of, I feel, like a unique American problem because we don't have sort of nationalized health systems where there is system-level integration to some degree already in place. So, but hopefully we'll get there. And then when you look at integrating system level, it can also look very different. So it could be a very basic at a distance integration, or it could be on site, which is sort of same as co-located, or partly integrated where we are co-located, but we have different EMRs, and it happens all the time. I worked in systems where we are in the same building, we can talk to each other, but the neurologist can't read my notes because psychiatry notes are under a whole another level of HIPAA. So that's what I mean. And then sometimes it's also, well, your insurance will cover like 20 visits with your neurologist, but 2 visits with your psychiatrist. So that's not a fully, because the payment system is not fully integrated. So the ideal, again, is a fully integrated system. So that's sort of really a lot of talk about like what the big items in terms of how we would want to integrate it. But when you think about it like this big thing, like, changing a system of care, I like to say, how do you eat an elephant? And the answer is piece by piece, because I don't know how else you would do it. And it's funny, every time I say this, my husband reminds me that I'm vegetarian. But anyways, so there are 4 components to integrating any, care system. One is making sure that you have the basic sort of patient care or home. So where's your home, where you go, whether it's your neurologist, your primary care doctor, your family physician. It's essential that there is sort of a home base where you get your care. And that wherever your home base is, there's a team that provides the care. So it's not that you're going to in this building to see your primary care doctor, in that building, or, in the next sort of block or next city, next town to see your psychiatrist, and in some other place to see your subspecialty care. And that the care has to be stepped. And by that I mean, when you're doing fine, let's say at age, 2 or 3, you get sort of preventive care to help you stay healthy, like do these things so that you can, prevent anxiety or you can prevent mood problems. And then if you have it, then, if it's mild anxiety, here's what you do. If you have higher levels of anxiety, here's what you do. So really kind of step to match where you're at so that not everybody's getting sort of everything or nobody's getting anything. And really matching where you're at. And a model to do that is the 4-quadrant model, which I'm going to talk about a little bit. So really, again, this is a busy slide, but the way to think about the 4 quadrants is if the vertical axis is the severity of mental health issues, and the horizontal axis is severity of your physical health complexity, where somebody falls within these quadrants. So you can have somebody who's in quadrant 1, which is low mental health, no physical health. Their needs are going to be minimal. In quadrant 2, you're going to have high levels of mental health needs, low levels of sort of physical complexity. So this is somebody, let's say their seizures relatively stable, or at least the pattern is sort of not really evolving and changing. You're not changing medications, but there are lots of behaviors that are getting in the way. In quadrant 3, where you have high levels of physical health complexity, not so much mental health complexity, and then finally quadrant 4, where they're all pretty complex. And this model is actually used, and I'm using it right now to not only set up this particular clinic, but it's used to set up services across the spectrum. So in my other role as sort of director for the consult liaison service, I'm using this model to set up services for the entire sort of range of what needs pediatric mental health care. in which, the patients with seizures would fall in quadrant 4 in general, but then within that quadrant, we can still divide it up into 4 further quadrants and look at it that way. So how do we use this quadrant? Like, these are the building blocks and steps. So first, we have to use screening, and I'll talk in a little bit why it is so important to screen and not just wait till somebody comes, like a parent comes to the neurologist or primary care doctor and says, I've had it, I need help, like now or yesterday. In some cases, a year ago. So it's important to screen very systematically to get at these issues, and then make sure that based on the screening, you have appropriate interventions that are available. So why screen? And less than 1 in 8 children who have mental health concerns receive appropriate care, which is why we need to screen, because a lot of this is because we don't pick it up. Oftentimes, by the time we pick it up by like the parent bringing the child to care, it's been 8 or 10 years of untreated symptoms on average, which is a really, really long time to go with untreated mental health symptoms. And really, if you think about how mental health diagnoses work, they get more complex the longer they go untreated. So that's a big problem, and that's why we need to really screen systematically. And it also takes really the stigma. It's not like, oh, I've met you 3 times and there must be something going on, so why don't we look at mental health in you? It's really looking at all of us have days that are challenging, and mental health issues are 1 in 4 have some mental health problem, and screening just sort of really takes all the stigma, all the sort of like guesswork out of it. And it provides really, and if it's negative, it provides an opportunity to educate, to have a dialogue, to build a relationship, and say, if these things happen, that I care about these things, you can bring it up to me. And it really sort of helps put into place early intervention. So in the last few minutes, I'll talk about sort of what this really looks like in terms of what we're trying to do here. So what are the screens that we're hoping to put into place? So the idea is to start with a quality of life screen. So the quality of life in childhood epilepsy, that's the sort of first orange block. And the idea is that we would have everybody who's seen in the clinic do this once a year to look at how is your quality of life because you have the epilepsy. It's not a normed scale, but it kind of really captures seizure-related variables. It captures sort of how that's impacting your coping and how that's impacting your self-esteem for the child, and then it also captures some family variables. And if there is a concern that is raised on that, there are cutoffs that we can put in place. And if the particular child is beyond a certain cutoff, they would get the next scale, which is the BASC, which is a behavior assessment, a very broad-based behavior assessment scale from behavioral health and mental health issues in children. And this is sort of probably a little bit more geared at some of the physicians in the group, but the most common scale that I know has been used in neurology is CBCL, which is another sort of broad-based scale. And there's a lot of sort of back and forth thinking that went on between like CBCL versus BASC and which is better. And if you look at the data, the CBCL is more sensitive, but it's also non-specific. So that if you have, let's say, lack of appetite, it flags it twice. It flags it in mood, it flags it in anxiety.